All right, so welcome everyone. Thank you all for joining today's virtual training with Dr. Gifford. I will not take too much time because we want to make sure to have some time at the end for questions. And I will let Dr. Gifford introduce himself. All right.
Thanks, Kayla. So my name is David Gifford. I'm a geriatrician and I work at AHCA, but also I serve as the Chief Medical Officer for the Kentucky Healthcare Quality Partnership. And one of the issues that Kayla has brought to my attention and has been questions around sepsis and sepsis transfers to the hospital. This is an issue that many of the managed care companies care about. It's clearly an issue that impacts our residents a great deal. And so I was asked to give a little presentation about sepsis and how to prevent admissions from sepsis. So let me share my screen. And Kayla has sent out the email with everyone. So you should have a copy of the slides. If not, you can drop something in the chat and Kayla will email you the slides if you'd like them. Let's start with just sort of thinking about what is sepsis. Sepsis is a syndrome that is the effect of multiple organs dysfunctioning and not operating at the same time in response to the body's fighting an infection. And that infection could be bacterial, fungal, or viral. It's typically bacterial. And it affects all the different organs differing amounts from sort of a catastrophic event to sort of minor effects. But principally, you will see it affect the respiratory system, the lungs, and people will have trouble breathing and low oxygenation level. It affects the blood counts, particularly often seen with low blood platelet counts or coagulation, blood clotting. The liver doesn't function well, so it doesn't clear medications and function. You see bilirubin increase, which is a marker of that. Kidneys don't work well, so you see increase in the markers that the kidneys aren't functioning and the urine output drops down. People get really confused and their blood pressure gets out of sync. This is typically more prevalent in the winter months, and that's because people tend to get sicker and get colds in the winter. That then creates an opportunity for superimposed bacterial infections. The common infections that lead to sepsis are pneumonia and urinary tract infections, but also cellulitis, diverticulitis, which is infections of the little diverticuli in the colon in the elderly, foreign objects or wounds. But about half the time, the source of the infection in someone who's septic is not really found. The pathogens or the bacteria that cause it, I said, are bacteria and fungal infections typically. Most commonly, it's gram-negative bacteria, but sometimes gram-positive bacteria. And a lot of multi-drug resistant organisms will cause sepsis because they continue to multiply because they are resistant to the antibiotics that people are started on, and you get an overwhelming infection that can lead to sepsis. The prognosis is terrible with sepsis. About 10 to 50% of all adults of any age who develop sepsis will die. And so this is a bad thing to get. The mortality rate increases dramatically as you get older, as you have other medical problems, so your organs aren't working as well as they should be. You have a lot of comorbidities. And that is the population we care for in our facilities, whether it be a nursing home or assisted living or not. And then if you get sepsis that results in shock where your blood pressure really drops and you have a lot of organ systems, then your mortality rate even goes up higher. The elderly who develop sepsis and then in the hospital but survive and are discharged to a SNF, about 2/3 of them will show some improvement in their ADLs, but about 40%, so 4 out of 10, show no further improvement. And if you do improve, that's a good sign for reducing your mortality. If you don't improve, it's a bad sign for your short-term mortality. Factors that are associated with people who are unlikely to improve following sepsis in the hospital, who we may get transferred to us, are people who have moderate to severe dementia, prior hospitalizations, age over 80, or they were in the hospital for more than 5 days. Those are all bad indicators that someone may not recover, and they may get sepsis again. Our residents who tend to be hospitalized with sepsis, who return to the SNF, who survive that hospitalization, what we see with those is that about 20% of them have an immediate decline in their cognitive function. So 1 out of 5 are worse cognitively than they were before they went, and they never get better, and they actually get worse over time. And again, this is typically in those who are over 85, those who already have some sort of Alzheimer's disease and related dementia, ADRD, and those with the sepsis that are worse sepsis. Again, here's just another study to show how severe sepsis is and what is the mortality for SNF residents versus the community elderly. And it's a much worse than because our residents are just sicker overall. So how do you detect sepsis? Well, sepsis is classically detected by really a quick change in the vital signs and the cognition and mental status of someone. So if you've got someone who's got an acute looking delirium, they are having a fever, their pulse rate's going up, their blood pressure is dropping down, the respiratory rate's going up, their oxygen saturations are dropping, you should have in the back of your mind, is this pre-sepsis or is this an early sepsis that's going on? So when a resident has a change in the mental status, you want to check their vital signs and their pulse oximetry to see if the change in the mental status is related to an infection, sort of a pre-septic condition. What's interesting is in this one study that looked at nursing home residents who were admitted to the hospital with sepsis and went back and looked at the medical record, often the vital signs and the mental status are missing in the medical record for many of the individuals. And a third of the residents who were admitted to the hospital with sepsis had no vital signs recorded in the medical record in the 12 hours prior to going to the hospital. So I just want to sink this in for a second. These are individuals who have sepsis, who are really sick, who go to the hospital. There's no recorded vital signs or sort of an assessment in a third of them before going to the hospital. So the question really is, when there's a change of status, what's the policy you have for getting vital signs? Because vital signs have a name. They're called vital because they are vital to understanding how sick someone is and whether they need to go to the hospital right away and what's happening. And the doctors and the nurse practitioners you call are going to know the vital signs if you're calling because someone has a change in their status. And if that you don't have that information, then the doctors and nurse practitioners are more likely to send someone to the hospital because they don't trust the individual giving the information if they aren't able to give them the vital signs that they have. There are some screening tools for sepsis. These are mostly used in the hospital. I listed them all here. The easiest one I'm going to highlight here is the National Early Warning Score because it's the easiest one to apply to our population. And here it is. It's really, and almost all these scores really have just different ways of assessing respiratory rate, oxygen saturation, blood pressure, pulse, their mental status, and their fever. And so if someone's got a lot of these and they're really out of whack, they have a lot of points, that really points to sepsis. If they don't have a lot of these, then it's less likely that they have sepsis. And so here you can see there's a grid here where you get points depending on how out of whack your respiratory rate is. Is it really high or really low? And as you get out to either the extremes on the table, the orange and sort of pink area, these are all signs that are bad signs with an individual. And I think we've all recognized that. And in the middle is kind of the normal range. And so this is an easy way to sort of sense when someone really is sick or not. Now, people who are sick for other factors, not just related to sepsis, may have some of these things out of whack as well. And this is just a good way of sensing, is someone really sick that needs attention or not? And so I like thinking about how these factors fit together. And I can tell you as a physician, when the nurses call me from the facilities where I work in, the I want to know these information because I'm trying to sense how sick is the resident and how fast do we need to act. Do we need to send them to the emergency room or not? What are the steps we need to do? Some of the common tests for residents who are suspected of infection, and you're all familiar with this, a blood test to look for their white blood cell counts and platelets, as I said, a blood test to look at their kidney function, blood test to look at lactate levels, which go up in when people have sort of a sepsis area. So you'll see a lot of doctors order a lactate level. Sometimes a plasma C-reactive protein that goes up when people have inflammation and infections. Some of these can be affected by other things, not just infection. So they're not perfect, but you take that in concert with everything that's going on. Blood cultures really don't work very well in our population, so you don't see them ordered that often. But if you're calling a doctor or someone who's working in the hospital, they may ask for blood cultures in the nursing home. Oxygen saturation, really key. Urinalysis and urine culture, chest x-ray, looking for pneumonia, and then just a good physical exam to see what's going on, and looking at, particularly paying attention to the wound and cellulitis, as I said. Treatment for sepsis, and this is, I'm not going to go into detail for treatment because this is really not a talk for the physicians or nurse practitioners on how to treat it. But basically, if someone has shock, which their blood pressure is really low, their heart rate's fast, they're really out of whack, these individuals need to go to the hospital. You need to, there's very, very few nursing homes that I know in the country that could manage these type of individuals, because often they're going to go into an ICU. They need IV fluids, they need continuous monitoring of their vital signs, lots of frequent blood tests. And so it's just not a population you want to care for. People who don't have shock, who don't have the blood pressure and vital signs really out of whack, still have to be pretty aggressive with them with IV fluids, and particularly since our population with heart failure, you get too much fluid and it causes other problems, and then they get fluid in the lungs and it affects them that way. These individuals, again, need to be watched really sort of closely. So again, managing these individuals can be really tricky. You really need to have a physician or nurse practitioner who's going to be available quite a bit if you're going to try to manage these individuals in your facility. So the best way to do this really is, how do you prevent people from getting infections in the first place, or how do you detect infections early enough so that they're treated with antibiotics so they don't progress to an overwhelming infection that triggers the sepsis response? That's the best way to do that. The other would be picking up residents early with their change of status using that news criteria that I just showed you in the previous slides. And then the other is discussing the goals. Are treating individuals with infections really aligned with their goals of what they want? Because often we send these individuals, if they get so sick that they get septic, as I showed in the previous slides, the likely they're going to get anything better, if they survive, they're going to come back worse than they were. So if their current status is something that where they don't really want to live the rest of their lives, then you can say with some certainty, if you have to go to the hospital with a bad infection, you're going to come back worse than you are now. They might save you, but you're going to be worse than now. So is that something you want to do? Because we can do certain things in the facility to treat infections. I'll talk about that a little later on. That may work, but if they fail, then it's unlikely you're going to see a lot of benefit from hospitalization. So having those discussions can help, I think, prevent people from going to the hospital and getting unnecessary treatment that's not going to really benefit them, that's not aligned with their goals. Now, it varies depending on the people you talk to. My parents are 91 and 92. I have the durable power of attorney for healthcare to making decisions for them. I've talked to them. They both live at home right now. My dad has made it very clear to me that he does not want to go to the hospital and does not want aggressive therapy at all. That's not what I would personally do at his age, but that's what he wants. And he's been said that since he was 80. So for 10 years in a row, he's been telling me that all the time. My mom is on the other end of the spectrum. She wants to go if there's any chance of getting better. She wants everything done over time. And I'm personally somewhere in the middle, but I've had those discussions with them. So I know when something happens, how to make those decisions. Having those discussions is really important with our residents and family because many of these infections and sepsis are a common thing that we see with our residents. So some general approach to how to manage pick up early detection of infections. Huddles are great. We all do our daily huddles. We have the morning huddles. One thing to think about with the huddles is incorporating it into is who looks sick, who just doesn't look the same, who's looking sick, who might have a runny nose, what's going on. And this actually allows staff to sort of keep a closer eye on. You may want to do more frequent vital signs on them, or you could actually start asking them to maybe stay in their room, socially distance, use a source control mask so that they're not spreading infections to others, so you don't end up with more people infected, because the more people infected, the more likely someone's going to progress to sepsis. Now, balancing and managing these infections is really a key issue. One is, I'm saying you need to identify infections early, take steps to treat them, and so they don't progress. And that has led to many of us over-treating infections. And so we result in over-treating infections because we're really worried about this really serious thing, sepsis. We need to balance that against overuse of antibiotics, which can lead to bad things too, which is C. diff, multi-drug resistant infections, diarrhea from antibiotics that are not due to C. diff. Certain antibiotics cause some problems. A lot of them have drug-drug interactions, particularly with anticoagulants and some of the other medications that are common in our population. And as I said, often this treatment may not benefit individuals, and it's consistent with their goals. So one has to think about the balancing act and having this discussion with their family as to what is the right course of action, like I've had with my parents. Now, the question is, who should get antibiotics and when? There's a couple of criteria out there. There's often the Gear criteria, which are discussed, but there's also a criteria called the Loeb criteria. I like the Loeb criteria because the Loeb criteria are designed to utilize patient and resident symptoms and physical findings without having to have any test results. The McGear criteria have essentially the same clinical symptoms and physical findings, but then also require lab results. The McGear criteria were designed to use for chart review after the fact to decide who had infections and who didn't for sort of public health research purposes. They could still be adapted and used for deciding who should have antibiotics or not, but they're good sort of for retrospectively looking back. The Loeb criteria look forward and sort of say, if someone has these symptoms, then they should start it on antibiotics while we wait for lab results to come back. And so they're much better. And you'll see CDC is now, or CMS has now incorporated the Loeb criteria into the state operating manual, where they used to mention McGear, and now they're starting to talk about the Loeb criteria. As I said, the common infections are here. The Loeb criteria cover these infections as to when to start antibiotics, which is helpful. So let's talk about pneumonia, because it's probably the leading cause for sepsis in the elderly. The best preventive measure for pneumonia sepsis is the vaccines. We have the pneumococcal vaccine, or the the PPV, the influenza, the COVID, and the RSV vaccine. And these really do work. They allow people so they don't get sick enough, particularly in the viral infections. They get really sick and it lowers their immunity, so they then get a bacterial infection on top of it. Then they get septic. And so having these vaccines really cuts down both the frequency of infections and any progression to sepsis. The other would be when the lungs sort of collapse a little bit and we're not able to clear out the normal sort of secretions in our lungs, that creates a great environment for bacteria to grow, because we're breathing air in and out, which have bacteria in it all the time, and we're just naturally clearing that out. But if the lungs collapse in little parts here or there, then that allows the bacteria to grow. And so this is commonly happens after people are in the hospital, they're not moving around, or they had surgery, or they're on a ventilator for some reason, like surgery. It causes little parts of the lung to not work as well. And so that's why you have those incentive spirometers. They're asking you to breathe really hard and take really deep breaths to expand the lungs out and open up the lungs that you have there. Now, in our population, they don't move around as much. And the less you move around, the more likely little bits of your lung are to collapse. And it's why it's good to sort of cough, get up and move around, take some deep breaths, use incentive spirometers to open that up. So we want to keep our residents a little bit more mobile and making sure that they are taking some really deep breaths every now and then, so that we don't have this area that allows for bacterial type infections to develop. And then using the lobe criteria, should someone have symptoms of pneumonia or lower respiratory tract infection, to decide whether they need to be started on an antibiotic. The Interact program has a nice care pathway for helping decide whether to treat someone with pneumonia early or not. And so, if you're really sort of anxious about, oh, I got to treat someone really early to prevent sepsis, but then I don't want to overtreat them, these pathways can sort of help you navigate that. The lobe criteria can really help you navigate that. And if you're following them, it also helps you if the surveyors come in afterwards and try to do a Monday morning quarterback. If there's lawsuits, you could say, I followed this protocol. As long as you follow the protocol, it will sort of cover you in the process. Now, it's important to also know that residents change over time, so they might not meet criteria on a protocol on day 1, day 2, day 3, day 4. They progress and they may change, so you need to be sort of always assessing the residents with what they're having, changes in their status. This is a graph here that looks at all deaths in nursing homes for any reason, just whether someone died in a nursing home or not, every week. And it looks from January 2015 on the left all the way through the end of 2021. And what you'll notice is the blue line is the number of deaths each week. And so you can see across the 15,000 nursing homes in the country, in the summer months, in July, we have about 8,000 deaths. And in the winter months, we have about 10,000 deaths. Every summer, it's always about the same. But some winters, in January and February, the deaths go over 10,000, and some go over 11,000, that red line that we see there. And those usually are winters where we had really bad influenza, or we had influenza that didn't match the vaccine very well. You can see on the right-hand side what happened in March of 2020. We had this massive spike of deaths, and that's really related to COVID. We could see another spike in January 2021 when we had the Omicron variant, but then we had the vaccine, and look at the number of deaths. We put all the steps we had in place, suddenly dropped dramatically across the country. This is a graph from NHSN data, just looking at the number of COVID cases in nursing homes. And what I want you to look at is there's a spike in January 2021 on the left. There's another spike in January 2022. There's another spike in January 2023. And we have a little bit of a spike again in this January of 2024. Now, we've seen the height of the spikes go down, and that's because so many of our residents have been vaccinated. Or they've had COVID, so they have some sort of immunity to that. And you can just see the effect of the vaccines sort of working generally in their population. But this just, again, underscores that every winter, we have these respiratory viruses that are spreading across the country. And so what do we do in the winter to help prevent these viral infections besides vaccine? Because that leads to pneumonia infections. So the vaccines that are available, as you know, is the COVID-19. Actually, I didn't update this with it's the new booster. And for those over age 65, they're recommending another one now. That's because the antibiotics, after about 4 or 5 months getting the vaccine, drift down, and it's just not as effective. And I know everyone's tired of getting the vaccine over and over again, but if our residents really don't want to get sick and go to the hospital, I would recommend that they get a second dose of the vaccine. There will be another version of the COVID vaccine in September or October. The CDC director confirmed that the other day on a call we were on. It will have an updated version of that. But someone asked them specifically, well, what about waiting right now? Does it matter if we get it right now or not? And I've talked to a couple other experts, and they all agree not to wait. They said because the new vaccine will have a different strain, and we're still seeing spread of cases with that. That's a good time to get it. So my parents, and I recommend many parents, to go out and get a second dose of the COVID vaccine. Influenza vaccine is annual. The pneumococcal vaccine, RSV, which did come out this fall, is again very effective at dropping that down. And as we know, we all have to offer and counsel residents and family this, document in the medical record. And in some of your states, you now are going to have to start recording this in there. I don't believe Kentucky has adopted that reporting, but we're going to, I think, see more of that over time. And another area that I think really didn't get enough attention and people are paying more attention to, and with CDC's new recommendations that just came out, they talk about the importance of indoor air quality. Basically, what you want to do on indoor air quality is you want to get indoor air out and outdoor air in. And how you do that doesn't really matter. But you just want more air circulating out, and that'll help really reduce infections. The best way is to use your HVAC system. If you're going to use that, you want to have a MERV filter of 13 or better if your HVAC allows that. The other is you probably want to turn your HVAC on so it runs continuously when you're in an outbreak, or maybe in the winter months, or when there's a community transmission of lots of viruses, or you're going to have lots of visitors. So you're coming up on Easter, you have a lot of visitors, you may want to turn your HVAC system on so it runs continuously over the Easter weekend. Just to help sort of reduce that. During school breaks, when more families come in with their kids, you may want to turn your HVAC system on to run continuously because you're getting more indoor air out versus outdoor air in. The other thing is that the HVAC system is pulling outdoor air in is key, because sometimes it's set on recirculate. And many of the HVAC systems will actually set to automatically convert to recirculate when the air temperature gets up over 70 or 80 degrees, because it's just more efficient to recirculate and cool the air in the building rather than bring hotter air from outside. Similarly, if it's really cold outside, it often sets to recirculate because it's cheaper and more efficient to recirculate warm air that's in the building, but now you're not getting indoor air out and outdoor air in. So again, looking at that and talking to the person in maintenance who's in charge of the HVAC system is really key. If you can, depending on the season and your building and the resident safety, opening windows and using fans is another way to do that. Basic air filtration systems, HEPA filters work well. How many, where you want to place them, that's a common question. I'd probably put them in residents' rooms, close to their beds when you're seeing an outbreak, if you're using that. But it's really up to you and how many and how often. There's a lot of cost with them and how big they are. But again, using some basic filtration systems can help. Let me shift to urosepsis. This is the second most common reason for sepsis in the elderly. And so really you want to first, if you can, prevent UTIs from happening. Before I get onto the slide of how to prevent UTIs, it's worth sort of understanding, how do UTIs develop in the elderly? Basically, UTI happens when bacteria get into the bladder. So how do bacteria get into the bladder? There's really only one way for them to get into the bladder. So they're going to come up through the urethra. And so bacteria are always sort of coming up and down through the urethra that we have. And the more frequent you are urinating and using the toilet, you're flushing out those bacteria. Now, if you use a Foley catheter and you're catheterizing someone, it allows the bacteria to go faster up into the bladder, and maybe you can sit up there in the bladder and stick on the Foley, and when you take it out, it's left behind, so you can see bladder infections a little bit more frequently when people have had those catheters in and used. And that's one reason we like to try to not use chronic Foley catheters, or get catheters out of people who are in the nursing home as quickly as possible, or who have been in the hospital, get it out as quickly as possible. But you want to make sure they stay well hydrated, so they're flushing out the bladder so that they can't grow bacteria in the bladder. Another question I often get is, what about cranberry juice? Well, if you acidify the urine in the bladder, bacteria don't grow as well in an acid environment. And cranberry juice is a little bit acidic, and if you drink cranberry juice, the theory is it can make your urine a little bit more acidic and lower the bacteria. Great theory, and actually it's been proven that it works if you drink massive amounts of cranberry juice. More cranberry juice than any of us want to drink ever, because you have to drink a lot of cranberry juice to acidify your urine. Probably the way cranberry juice works is it's just hydrating people and causing them to flush out their bladder. I don't really care one way or another. If cranberry juice is the way it convinces people to drink a little bit more and flush out their bladder and they think it's the acidification, I don't really want to care about it because it's still working to prevent the infection. But I just wanted you to understand that it's not the cranberry juice, it's just drinking the fluid that they have. Now, when people do develop a UTI and they have the lobe criteria and they meet the criteria for that, you want to make sure that they align the antibiotic selection with the resistance pattern of the bacteria in your facility or hospitals. Every hospital and nursing home and every community in this country has a different resistant pattern. E. coli, the common bacteria that causes a UTI in some communities, is very resistant to ciprofloxacin, commonly used to treat UTIs. In others, it's really resistant to Bactrim, the sulfur drug, and it changes in different areas. Now, doctors don't always know what the right resistant pattern is in the community, and if I like to start ciprofloxacin for UTIs, I'm going to call and start that. But if you have a resistant pattern in your facility to Cipro, that's not going to work. It's going to allow the urinary tract infection to blossom further and may lead to urosepsis. So you want to use what's called an antibiogram. An antibiogram here is an example of it. These are a table that you can get from your lab. So wherever you order your labs, they should be able to do this, and it'll show you each column. It depends. Sometimes it's oriented differently, but generally each column is the different types of bacteria that they have grown over the last year, last 6 months, whatever you ask them for, and it'll show you what percentage are resistant to each of the different types of antibiotics. So you can see in this example here that the Klebsiella pneumonia, the middle column there in the middle, 0% of them are resistant to ampicillin, which is really good. But you can see the Proteus, 100% are resistant to amoxicillin or augmentin that they have there. And you wouldn't want to use that antibiotic in your building. So it's really important to understand that resistance pattern and how you want to do that. So your infection preventionist should be getting an antibiogram. If your lab doesn't have one, or even if they have one, you may want to get one from the hospital. If you're taking admissions from 2 different hospitals, each hospital will have an antibiogram for their population. And when our residents go to the hospital and they get Foley's in, there's a good chance they're getting exposed to the bacteria that are in that hospital. So you want to know what the antibiogram is for that hospital. The INTERACT program, again, has a nice care pathway that you could use for when to treat. It incorporates the lobe criteria into it. So it's a nice process for doing the UTI. Let me switch over to cellulitis. So cellulitis, again, is another common reason. It's an infection of the skin. And so you want to prevent cellulitis from occurring in the first place. Basically, for cellulitis to occur, bacteria have to get through the skin into the underlying tissue just underneath the skin to grow and cause the infection, and then it allows it to spread. So the question is, how do you prevent bacteria from getting through the skin? In the winter months, when skin gets dry because of the dry, cold air or low humidity environments, the skin will get dry and crack, and particularly on the feet or in different areas, and particularly the lower legs, and especially with our residents who have a little bit of dependent edema or edema from their heart failure, that swelling they get. When you take your sock off, you can see the little strip around there. That's that little bit of edema fluid. Well, that fluid is great culture media for growing bacteria. It's just perfect for how to grow bacteria. So if you get cracked skin and you have a little bit of edema, bacteria get in there, you're more likely going to get cellulitis. Certainly if you have wounds, pressure ulcers, diabetic ulcers, venous stasis ulcers, those allow bacteria again to get in, because you've got a clear break in the wound. You've had surgery where they've cut the skin. Again, those are all ways to do it, but keeping the skin hygiene issue. So you want to use a nice lotion that keeps the skin soft, dry, and supple, so you don't see the drying and cracking, and you'll see a decrease in cellulitis with that. Caring for the wound, so you don't want to let a lot of fluid and necrotic tissue, because that all becomes a nidus for the bacteria to grow in a wound that then could spread into the wound. Enhanced barrier precautions, which CMS just came out with, is another way to prevent the multi-drug resistant organisms from spreading into the wounds. And then should they spread into a cellulitis, you don't want to have a sepsis or a cellulitis with a multi-drug resistant infection, because it's just a lot harder. So that's why the enhanced barrier precautions trigger anyone who has an indwelling catheter or indwelling device or a wound. Those are all areas that allow bacteria to set up shop and get in and cause infections. And that's why they use those as the trigger for enhanced barrier precautions. Frequent skin checks, not just for pressure injury and pressure ulcers, but really to see, are there some redness and swelling or early signs? You know, I think you've seen sometimes physicians or others, they'll draw a little marker around the redness to see if it's spreading, because we all get a little redness around a wound or infection, a wound or an opening. But if often our bodies are able to care for that ourselves. But if it starts growing and spreading or streaking, and so sometimes drawing a little marker can help you do that, that's really valuable information to decide whether you need to start antibiotics sooner or not with the individual. And again, using the Loeb or McGeer criteria for initiation of antibiotics for cellulitis is really helpful. So I wanted to give you an example of comparing the McGeer and Loeb criteria. Here, the McGeer criteria are purulent drainage, like pus, and 4 of the following symptoms. Loeb criteria is drainage and 2 of the following symptoms. So a little bit lower criteria for starting antibiotics with Loeb than McGeer, but you can see almost the same symptoms that they have between the two. I don't really care which one you pick. Pick one and use it, and it'll help you do antibiotics more carefully with your residents. Remember, I said it's really important whether someone meets criteria or not. You really want to make sure you're aligning the aggressiveness of the treatment with their quality of life and their overall goals. This just gives you a sense. Remember, most people who have sepsis who are going to go to the hospital are going to end up in the ICU. This was a study looking at elderly individuals who went to a hospital, who spent time in the ICU. This was a study looking at who should go to the ICU or not. And that doesn't really matter. What you can see is in both groups that went to the ICU, 6 months later, only 60% of them are alive. So that's 4 out of 10 people who go to the ICU for any reason are going to die in the next 6 months. And the functional level of these, and this is for everyone, just any elderly, but of our residents who are coming from the nursing home, who have a lot more issues, this survival curve is a lot worse. Certainly, whether you're alive or dead is an important outcome that many people care about, but also a lot of people care about their functional level and what's happening. And so this is a slide that looks at the impact of hospitalization of nursing home residents on their ADL function 90 days after coming back to the hospital. So if they survived the hospitalization and came back, what happens? And so on the left-hand side here of the chart, you can see what was their ADL score over the 6 months before they got hospitalized. And with all our residents, they tend to be declining a little bit, usually about 1 ADL dependency every 6 months. And you can see that line is going down a little bit. The gray line going up and down is when they had the hospitalization. And now the dashed line shows you what their ADL score was after the hospital stay. And what you can see is they come back, we can't get them back to baseline, and now their rate of decline is worse. Going to the hospital with pneumonia or any infection is just bad for our residents, and it really impacts their functional level. And so if their pre-hospitalization functional level is one that they are not happy with, and that's not where they want to live, you can tell them going to the hospital is going to result in you being more dependent and getting worse faster when you come back. And that can help with the decision process. So this is the data. That's why my dad says, I don't want it all. My mom, she's still happy with it. I'm not saying there's what's the right answer. You just want to make sure that families and residents are informed so they make the right decision. What you find is particularly people who have moderate to advanced dementia, that a lot of times they'll say, hey, that's not what I want. And about 2/3 of them will say, I don't want to go to the hospital or ER anymore. I don't want aggressive therapy. I don't want a lot of antibiotics, or just give me oral antibiotics in the nursing home and let's see if that works. If it works, great. If it doesn't, we don't need to do anything. Um, but that also then helps cut down on your sepsis metrics with the managed care in the hospitals, because they're not going to the hospital to get diagnosed with sepsis. There's a study looking at the hospitalization for pneumonia for SNF residents, and who were then transferred back. Almost 40% of them died within 2 months. Half of them had a severe disability in their ADLs that they didn't have before. And residents who had no or little ADL impairment prior to the hospitalization with pneumonia, 2/3 of them now had a significant decline in their ADLs of more than 2, or died within the next 60 days. Again, just underscoring what happens with these infections in our population is not good, and why we want to take steps to avoid it or manage it in the facility the best we can. Here was a study that looked at a couple of different questions. They looked at, do antibiotics prolong life? For residents who are suspected of having a lower respiratory tract infection, the answer is yes, antibiotics will prolong your life by a few months at best. Antibiotics for people with moderate to severe dementia for treated for UTIs, whether they got anything, did not really impact their survival. The other thing was that for pneumonia, whether you treated them with oral antibiotics or IV antibiotics or IM antibiotics, there was no difference. And so there's no benefit of sending them for IV or IM, again, unless they just can't take oral antibiotics. And so if you're worried about, want the additional survival for pneumonia, oral antibiotics are not a bad choice for pneumonia. Again, if it's aligned with the care needs and the wishes of the family, if they want. This was a study that just looked at this broader issue of how you integrate goals in. They took individuals who had been going in and out of the hospital over the last 6 months. So they've been hospitalized a couple times in the last 6 months. And they sat down with a palliative care consult team. And the goal was not to try to get them to DNR or do not hospitalize or get them into hospice. It really was to sit down and have a discussion about what were the realistic goals of care and what were the barriers to getting them home, given where they were in their life trajectory and given their current wishes. And they also asked whether that hospitalization was consistent with the goals of care or the worsening of symptoms, and where it would be best managed, given all the things like I just described, having that discussion with the family. And what they found was they cut hospitalization rates by 20% because many people decided not to go to the hospital, like my dad, but it's not going to work everywhere. My mom would still go to the hospital. People were able to discharge people home so they could die at home. And patients were much more likely to die either at SNF or at home rather than going to the hospital and dying, because they had had these discussions up front. So here was a facility in Iowa that I was working with that had a hospitalization rate of over 20%. And they sat down and started having these discussions with their families and residents. And they tracked their hospitalization rates. And from October through January, when they started having these discussions, they lowered their hospitalization rates down to 6%. They continue to have this and refine their process such that by last fall, their hospitalization rates were down to 1% in the facility when they were having these discussions with family. So just to recap and then open it up for any questions you have, you want to implement preventive measures for sepsis, vaccines. You want to prevent the atelectasis, that little collapsing of the lungs, with movement and sense spirometer. Keep people well hydrated, frequently toileting. Make sure the skin hygiene is really well cared for. Make sure wound care is well done. Any necrotic or dead tissue gets cleared out. Utilize enhanced barrier precautions when possible. Minimize the use of catheters or indwelling devices, or use them for the shortest duration as possible. And then I should have added, use the Loeb criteria for starting antibiotics, sit down with your medical director and see what he or she thinks about using the low criteria. So let me stop there. I know I threw a lot at you with the slides. See what questions you have about sepsis or how to prevent sepsis issues. You can either put your comments in the chat or you can take yourself off mute if Kayla will let you come off mute to ask the question directly.
I think you explained it so well.
I think I put them to sleep. It was right after lunch and everyone's sound asleep. That's what it is with that. But if you have questions about it, you can reach out to Kayla or myself. I would encourage you to sit down and talk with your nurse practitioner or medical director about the issues. I think it gave you some ideas where to look for this. But we are seeing, a fair amount of sepsis transfers. And so we do need to figure out a way to sort of reduce that. And if we wait too long, as I said at the beginning, there's nothing to do at that point. You need to transfer them there. So really, how do you treat these early or prevent people from getting infections in the first place? And with that, Kayla, thanks very much. And I look forward to actually meeting you all in person in Kentucky when we come out there to do some workshops with you, or to see you at the Quality Summit in San Antonio.
Thank you, Dr. Gifford, and thank you all for joining. Just so you all know, this was recorded, so we will send out the recording afterwards. And I will put my email in the chat really quick. If you were not originally on the calendar invite, please send me an email so that I can make sure to get you these slides and the recording. All right. Thank you all for joining. See you soon.